Tonight, we have two articles that we will be covering. The first is Contemporary Management of Acute and Chronic Mesenteric Ischemia, a 10-year experience from a multi-hospital healthcare system. And we have the authors from that article. We're very excited that they were able to join us. Next, we also have the outcomes of balloon expandable versus self-expanding stent grafts for endovascular repair of iliac aneurysms using iliac branch endoprostheses. And also the authors are joining us. Our two host institutions this evening are Hofstra University Norwell and also the University of Connecticut at Hartford. The faculty from each institution, we're thrilled to have Dr. Jeffrey Sippel to join us, and also his second-year fellow, who will be presenting the first article from the University of Connecticut, Dr. Ted Gifford, and his first-year fellow, Dr. Laura Healy, will be joining us. As I mentioned, our authors are here as well. From the mesenteric ischemia paper, Dr. Chair is here with his PGY4 integrated vascular resident, who is the first author on the paper. They will be helping answer questions. And then from our endoprostheses article, Dr. Oderich may be able to join a little bit, but we're lucky to have two of his postdoctoral research fellows, Dr. Lima and Dr. Tenorio, to help answer questions about their article. As usual, we have special guests, which will be helping us moderate. Dr. Jeff Syracuse will be moderating, and he is an associate professor of surgery and a program director in Boston University. And then this month, we have a very special second moderator. Vamsi Pirelli is one of the interns, the JVS interns this year. And so we're excited to have him also moderating the second article. And he's an incoming integrated vascular resident at Loyola University. So this is kind of an exciting opportunity. And Dr. Syracuse has been able to mentor him through this process. Just a couple of housekeeping items. If you could please stay muted. You can put your comments and questions in the chat for the discussion. The moderator will help us answer those. This event is being recorded. We do have it for on-demand access. It's posted on the SVS website. There will not be a June JVS Journal Club online because of the VAM, and I have a slide about that next. But we will have our next episode, or our next version in July. It's July 14th at 7 p.m. Central. We've finalized all the May through August dates, and they're posted. And then we're working on the September and December dates. So, Paul, do you want to mention just a little part of the VAM advertisement?
Yeah, thank you, Misty. As you know, JVS, every VAM gets an hour or two to talk about how we communicate in vascular surgery. And this year, we're trying to do something innovative. If you go on that QR code, it'll take you to a website where you can pose some questions, topics to talk about. And leading up to VAM, we are going to collate those questions and topics. Maybe the more controversial, the better. As you know, one of the most, and this went viral worldwide, the Bikini Gate was something that was centered around what we do and what we put out, and something that, you know, was important to us. But we just want to talk about what you want to talk about. And that's what the JVS Hour is going to be about. So thanks, Misty.
All right, well, I will stop sharing my screen and we will have our first faculty introduce the first article, which is the mesenteric ischemia article.
Can you all see my slides?
We can.
Good evening, I'm Jeff Silky from Hofstra Northwell on Long Island, New York. One of the vascular surgeons here, and I'm joined with AJ, who's one of our second-year fellows, to discuss the paper. So I'm going to give a brief introduction to mesenteric ischemia, and although it's brief, I think it'll be a nice segue into AJ's discussion of the paper. So thank you all for having me. So just to define mesenteric ischemia, it's when the perfusion of the visceral organs fails to meet the metabolic requirements. And we break this down to types of processes here. Either you have an acute mesenteric ischemia or a chronic mesenteric ischemia. And the acute mesenteric ischemia is obviously broken down into the etiology. So this can either be embolic, it could be due to in situ thrombosis, a chronic disease, that we call arterial thrombosis, venous thrombosis, or non-occlusive mesenteric ischemia, or NOMI. To break this down a little further, and just give it a little more background about each type of mesenteric ischemia, arterial embolism is actually decreasing in incidence. This used to be the most common type of, most common etiology of acute mesenteric ischemia. But due to the new therapies and anticoagulation for cardiac disease, including cardiac arrhythmia and cardiomyopathy, this is not the most common form of acute mesenteric ischemia anymore. And so we are seeing that this is decreasing in incidence. It presents with an abrupt onset and rapid progression. It's usually either thromboembolic or atheroembolic, depending on the etiology being a thrombus in the heart or elsewhere, or due to the atheromatous plaque that is shed off as an embolic phenomenon and lodges in the SMA. The SMA is the most common mesenteric artery involved due to its oblique origin. Typically, it spares the first portion of the small bowel and the ascending colon, and the treatment is embolectomy and followed by bowel resection. Obviously, important to perform embolectomy first, identify the revascularization components, take a look at the bowel, warm everything up, and then just decide whether or not you need to resect any bowel. Typically, this results in a second look laparotomy 24 to 48 hours later, and the bowel and the abdomen is temporarily closed during that time period. Arterial thrombosis is now the #1 cause. It's due to in situ thrombosis of chronic lesions. Here, the origin of the SMA is occluded, and all the small bowel and the right colon are affected. Ischemia in this particular situation is more insidious due to the collateral circulation that is formed from the chronic lesions. And the treatment is retrograde stenting versus bypass. For venous thrombosis, in terms of acute mesenteric ischemia, this occurs most commonly in middle-aged and elderly patients. It says an equal gender distribution where overall there's a slight female predominance for acute mesenteric ischemia, but particularly for venous thrombosis, there's equal gender distribution. This also presents with an insidious onset of diffuse abdominal pain, which may be present for days to weeks. The treatment for venous thrombosis begins with anticoagulation. And if the patient develops peritoneal signs, lactate acidemia, or progression of symptomatology on AC, then one may consider thrombolysis or thrombectomy. And for the non-occlusive mesenteric ischemia, or NOMI, this typically occurs in patients that are critically ill with hemodynamic instability. You see this most often in ICU patients. It has the highest mortality because of its association with multi-system organ failure. It's the most insidious onset and protracted clinical course. Many times it results in persistent vasospasm that's difficult to correct. The treatment initially is resuscitation with correction of the factors that led the patient to be critically ill and hemodynamically unstable in the first place. And if necessary, one may perform catheter-directed papaverin infusion or PGE1 infusion, prostaglandin E1 infusion. Chronic mesenteric ischemia, one may consider a different diagnosis altogether. The presentation typically occurs in cachectic middle-aged women. It's typically found in patients with a long smoking history, and it's a disease mostly of atherosclerosis. Presents with postprandial abdominal pain that occurs 15 to 30 minutes after eating, which leads to food fear and weight loss. In terms of the pathophysiology, what you see is atherosclerosis of the mesenteric arteries, which lead to stenosis and or occlusions. these patients have a rich collateral network and really only become symptomatic when there's two vessels involved, especially for older patients who have developed, more collaterals over their lifetime. And the treatment here is either endo or open for the most part. An endovascular methodology of treatment is, balloon expandable stent, and an open method of treating this is either an antegrade or retrograde mesenteric bypass from the aorta or from the iliacs. So I know this is short, but hopefully this is focused and provided a good introduction into AJ's discussion of the paper. And I'm going to stop sharing my screen now and give it up to AJ.
All right. All right. Good evening, everyone, and thank you for having us. I'm going to be talking about the paper titled Contemporary Management of Acute and Chronic Mesenteric Ischemia. It's a 10-year experience from a multi-hospital healthcare system. The objective of this paper was to define the predictors of postoperative morbidity, mortality, and patency loss for acute and chronic mesenteric ischemia. This is a retrospective cohort study. It's from multiple hospitals within a single network over the span of 10 years, from January of 2010 to December of 2020. In terms of methodology, all patients that had revascularizations for acute and chronic mesenteric ischemia were included. Patients that had treatment for median arcuate ligament and mesenteric venous thrombosis were excluded. Patients were clumped into acute mesenteric ischemia if they had symptoms less than 2 weeks onset, whereas patients that had symptoms for more than 2 weeks were included in the chronic mesenteric ischemia group. And this group also included patients that had acute and chronic, so patients that required emergency operations but had a history of chronic mesenteric ischemia or symptoms for more than 2 weeks. In terms of the descriptive analysis for some of the data, the acute mesenteric ischemia group was stratified based on the treatment, and this was open endovascular or retrograde open mesenteric stent. For chronic mesenteric ischemia group, they were stratified as open and endovascular. The variables that were collected were all the demographic data, including the comorbidities, the operative details, and the postoperative complications. The lesions in these patients were stratified based on the CT where it was available, and they were stratified into normal if the lumen was showed no narrowing, mild if it was narrowed 1 to 49%, moderate if it was narrowed 50 to 74%, and severe if it was narrowed 55 to 99%. The primary outcomes for this paper were 30-day morbidity and mortality, and the secondary outcomes were loss of patency. In terms of the results, in the acute mesenteric ischemia group, they had 148 patients with a mean age of 69 years. 86% of these patients were Caucasian. 26% presented with peritonitis, and 60% with pain out of proportion to physical exam. 32% were clinically septic. 90% of these patients with acute mesenteric ischemia underwent surgery within 16 hours. All patients had surgery within 72 hours. 60% had open repair compared to 24% that had endo, and only 16% underwent retrograde open mesenteric stents. Fewer patients in the endovascular group had peritonitis, 19 versus 29%, although this wasn't statistically significant. Sepsis on presentation was also lower in the endovascular group, 25% versus 36%, again, not statistically significant. The interval to intervention for the endovascular group was longer. It was 6 hours versus 10 hours. Just some of the details in terms of the operative intervention. For the endovascular group, 80%, almost 80% patients had angioplasty plus stent, and most of the stents or interventions happened in the SMA. One important note here is that the 3 patients underwent suction thrombectomy, and out of that, 2 patients had a mortality within the 30-day period. In terms of the type of stents, all patients had balloon expandable stent placed. Interval to surgery was about 10 hours, and about 61% patients in the endovascular group required a bowel resection. For patients that had open intervention, this was roughly about 24%, and most patients had an embolectomy. However, out of the 20% patients that had bypasses done, they had 60% patients that had Dacron conduit used, and out of those 6 patients ended up requiring re-intervention for intra-abdominal sepsis. In terms of the results, the 30-day mortality in the entire cohort was 31%. The major adverse events happened in 49% of the patients. In their analysis, the etiology for the acute mesenteric ischemia did not change outcomes. The odds ratio was 1.30 with a confidence interval of 0.77 to 2.19. There were no the patients that had open revascularization had lesser odds of needing a bowel resection, with an odds ratio of 0.23 and a confidence interval of 0.13 to 0.61. And some of the factors associated with increased 30-day major adverse event were sepsis on presentation and a history of diabetes. And some of these, the history of diabetes we've seen is also associated with poor outcomes in other vascular pathologies. In terms of the secondary outcomes, which is the patency rates, there were no independent predictors for the loss of patency. And we see that the patency for open interventions was higher. The 6 months was almost 100%, compared to 87% for endovascular intervention and 80% for ROMs. In terms of the results for chronic mesenteric ischemia, this group had 259 patients with a mean age of 71 years. Again, 90% Caucasian, 21% patients had open intervention compared to 79% endo, which is pretty consistent with the literature that's out there. In terms of the procedures performed, all patients had, the patients that underwent open interventions had bypasses, and most of them, actually all of them had a Dacron or PTFE used as a conduit. In terms of endovascular interventions, angioplasty plus stenting was the most common interventions used, and the SMA was the most common vessel treated in 63% of the patients. In terms of the timing, the operative time for open intervention was 300 minutes compared to endovascular intervention where it was 91 minutes, so big difference there. In terms of their outcomes, postoperative major adverse events occurred in 12%, that's the overall cohort. In the open population, 27% had major adverse events versus 9% after endovascular interventions. For predictors, patients that had small bowel surgeries previously had a higher associated 30-day readmission. Odds ratio was 2.98 with a confidence interval of 1.23 to 7.13. Patients that were inpatients prior to interventions or had a history of CKD also had an increased 30-day mortality. And you can see the odds ratio were close to 3 in both of those subcategories. In terms of the primary patency rate, before we come to that, 25% patients had recurrence of symptoms, 29% in the endo group versus 13% in the open group. So there's a higher rate of recurrence of symptoms in the endo group compared to the open. And there is a higher rate of re-intervention in the open versus endo group, 9% versus 21%. In terms of the patency rates, 100% patency for open operations compared to about 95% patency for endovascular interventions in the chronic mesenteric ischemia group. So in terms of discussion, this paper does, does show that a lot of the things that have already been discussed in previous papers, the morbidity for acute mesenteric ischemia has been pretty high despite the use of endovascular techniques to salvage these patients. The systemic disease at presentation, or how severe the patient's condition is at the time of presentation, is pretty much determinant of the outcomes in that patient. Revascularization type could affect postoperative course. Like I mentioned, patients that had lysis did not seem to do that well. And again, patients that had open interventions for AMI required had less chances of bowel resection. And open interventions, decrease the rate of bowel resection. In terms of chronic mesenteric ischemia, there's higher postoperative morbidity for inpatients and for patients that undergo open surgery. Reinterventions and symptom recurrence rates are greater with endovascular treatment. However, endovascular first approach should still be considered, but these patients strictly monitored for symptom recurrence or disease progression after treatment. There are some limitations to this paper. It was a retrospective analysis with possible selection bias among treatment group. There was no ability to deduce complex clinical decision-making at the time of the surgery. So patients that had open or endovascular, and why these clinical decisions were made at that time. The comorbidity data coded from electronic medical record limits measuring reliability, and the overall follow-up in both the groups was limited. In the acute mesenteric ischemia group, it was just under a year, and in the chronic mesenteric group, it was under 2 years.
Right. Thank you, Ginger, for that great presentation, and thanks to Dr. Andraska and colleagues for the great paper. I'll start off with my first question, then we'll go with the questions in the group chat. My question is for the authors. The paper describes a 4-hour delay for endovascular interventions versus open interventions. What was the reason for that delay? And do you think that that additional ischemia time could attribute to the high rates of bowel ischemia seen with endovascular interventions?
Would you like me to take a stab at it, Dr. Andraska, or would you like to answer?
Sorry, I was just answering one of the chat questions. Do you want to answer this and I'll answer the chat?
So as you can imagine, multiple services are involved in the treatment of those patients, and sometimes vascular surgeons are called first and sometimes they're not. So there's a lot of variability in terms of who sees the patient first, who explores the abdomen, what time you're called. So that this really factors in. Sometimes we're not even called until the second look operation. So this is what really has generated this delay whenever you average it. Another potential source of delay is when a bowel resection is performed, and then you put a Doppler probe on the mesentery and then you have a good signal, and then you're fooled that this is enough, and then you don't do anything, and then you take the patient back at the second look and you see that there's progression of the bowel ischemia, and then you do a bypass. So those are, I think, the two most common causes for the delay. One is being called late, and second, maybe not doing the revascularization at the index exploration.
Thank you. The next question is from Dr. Humphreys, which I think you answered in the chat, but I'll read out for everyone. For the authors, does the high use of Dacron for bypass conduit reflect an antegrade bypass versus a retrograde bypass from the ilia?
It's sorry, I put it in the chat, and I can't type that fast. It's much easier to just verbalize it, but I think it's really related to the surgeon's preference. and perhaps also how long the surgeon has been in practice. I think that Dacron is much more commonly used in surgeons who have been in practice for a longer period of time, and perhaps with antegrade bypasses, there's a perception maybe that if the inflow is from the iliac, it's a curve. And maybe ring reinforcement with PTFE may be protective. But also what is unclear is which one is really more resistant to infection if you have some degree of contamination. Is it rifampin-soaked Dacron, or is it the PTFE? So that remains to be seen. But you can also see over time that ROMS has become definitely more popular in those patients where the likelihood of contamination is higher.
And our next question is from Dr. Forbes. This question is, AMI was defined as 2 weeks of symptoms. That includes a wide variability of severity with acute embolic SMA inclusion at one end and those with a more indolent course at the other. How did the paper consider this variability in urgency and presentation?
Oh, sorry, I was typing answers. I apologize. So that was a definition that had been in the literature in previous reports of AMI. The majority of these patients did present in the acute setting, and however, there is a proportion of patients, especially in the in situ thrombosis group, that have underlying disease that present in that more acute on chronic state, but they still, when they came to the hospital, they were still, peritonitic and needed an operation. So we wanted to make sure to include those patients. But I agree, there is a difference in the patient population itself, which our multivariable analysis was hopefully accounting for. But again, with retrospective analyses and in such a diverse patient population such as this, it's difficult to control for, but we felt they needed to be included.
And our next question was from Dr. Demuzio. For revascularization in acute and chronic presentations, does the dogma of trying to revascularize as many vessels as possible, celiac, SMA, IMA, still stand, or do most just go for the SMA?
So preliminary data, so we didn't have enough stents in the acute group to really do that analysis, but preliminary data in the chronic group is showing similar results regardless of how many vessels you stent. But that's something we're actually looking into in the future.
The next question is from Dr. Gifford. Was increasing time to procedure from diagnosis associated with increasing morbidity or mortality in acute mesenteric ischemia? Anecdotally, there often seems to be a delay in diagnosis with the problem worsening outcomes.
Absolutely, and I think that's a really interesting problem and question in the field. We not only saw that increased time to OR associated with worse outcomes, but delayed vascular consult was also associated with worse outcomes. And so this is actually an initiative that we're working on now in getting kind of earlier vascular consults and getting these patients seen earlier by a surgeon.
So this ties in with Dr. Forbes' question as to who does what first, the embolectomy, the general surgeon, the acute care surgery, and what Dr. Andraska has mentioned is that we had separately looked at acute mesenteric ischemia, and the delayed vascular consult was associated with increased morbidity and bowel resection, to the point where we're working on a code mesenteric ischemia protocol that involves all the stakeholders, the ER, the acute care surgeons, and all that. So from the time you have a CTA diagnosis, we want everyone to be paged at the same time once a diagnosis is made, so that they are involved at the time of the initial exploration, so that you don't experience any of those delays. We have an artificial time of door to mesenteric revascularization time of 360 minutes, based on what we have seen in the literature. So we're trying to treat this like an acute stroke or a ruptured aneurysm and so on, and see if those metrics make a difference in terms of being able to reduce that 30% mortality that we still see even in this modern day and age.
Next question is from Dr. Bachara. Not sure if I missed it. Was there a difference between covered versus bare metal stent patency and reintervention for chronic mesenteric ischemia?
We did not see a significant difference in our study, but in previous studies, there has been a suggestion. So that is something we can certainly look to in the future. But in this initial survey, we did not see a difference.
Dr. Pierre Lewis asks, has the time delay ever been captured in data? For instance, how long is the patient in the hospital or the ED before the intervention is done? Similar to a door to PCI in cardiology.
Yeah, and that's what Dr. Scher was alluding to earlier. We do have the minute from first vital sign in the ED to time of the start of the operation, and that every minute is associated with a higher and higher risk of adverse outcomes. But again, that doesn't really account for, if it was an outside hospital transfer or exactly when the symptoms started, but we do have this kind of surrogate measure.
And then the last question I have is from Dr. Syracuse. He asked, can you comment on lysis in acute mesenteric ischemia? You had 2 of 3 patients worsen during lysis.
So it's not something that we do primarily. Those are patients that we typically treat as they are transferred when lysis was initiated somewhere else by non-vascular surgeons, and then they don't get better, and then the outcomes are what they are. We have done some suction thrombectomy for those patients because we think it's more expeditious with mixed outcomes. But this is what those lysis patients are from. Transfers essentially, sometimes with a catheter still in place and worsening clinical symptoms for us to operate on.
Well, that was a lot of great conversation and questions. I think there was one more question left behind that I will let you type out. I'm sorry that you typed out a few in the beginning, but we want to move to the second article so that we get enough time for each of them. There was a lot of good discussion there. So we'll now turn it over to Dr. Gifford to kick us off with the second article.
All right, just have to remember to unmute myself. Thank you all for the opportunity to be here tonight, and for myself and for our fellow Dr. Healy to review this excellent paper. Look forward to everyone's feedback. So I'm going to be talking about the endovascular management of iliac aneurysms briefly. These are my relevant disclosures. So a little bit of background here. What's the significance of a concomitant iliac aneurysm when you're evaluating a patient who has an infrarenal aortic aneurysm, and in particular when you're contemplating endovascular management of that? Well, if we look at some of the literature, roughly a third of patients will have a concomitant iliac aneurysm when they present with a AAA. If we look at a large registry, the Eurostar registry, in that registry of over 6,000 patients, about 28% had a concomitant common iliac artery aneurysm. We look at the outcomes of those patients who had iliac aneurysms versus patients who did not. We find that patients with a concomitant iliac aneurysm have a higher rate of inadvertent internal iliac artery occlusion, type 1B and type 2 endoleaks, secondary reinterventions, and aneurysm rupture. So clearly the presence of an iliac aneurysm in conjunction with the AAA increases the complexity and the likelihood for downstream failure of endovascular therapy and increases the likelihood of reintervention. So it's important that when we contemplate treating these patients that we pick the right treatment modality and that we get a good and durable distal seal as well as the proximal seal for the EVAR. What are some of the ways that we have to treat this? So if we're just talking about endovascular management, we're going to exclude open surgery for the time being. Historically, there were a few different treatment options. There were flared iliac limbs, which are limited to the sizes available by the different manufacturers, essentially 27 or 28 millimeters. And there's also exclusion of the common iliac aneurysm by the traditional coil and cover approach. This is coil embolization of the ipsilateral internal iliac artery, and then sealing in the more distal non-aneurysmal external iliac artery. What are some of the limitations of this? Well, for one, in today's day and age, we kind of want to fail forward. So we want to think about the next problem that we're going to face with this patient. If we cover their internal iliac artery, we're compromising some of their collateral flow. That's not just important for lower extremity perfusion, but also for spinal cord ischemia, as we know that, and as we cover more and more of the paravisceral or thoracic aorta, we increase the risk of spinal cord ischemia. And so preserving internal iliac artery flow is important to maintaining good spinal cord perfusion. If you have patients that undergo bilateral internal iliac artery coverage, they can have kind of devastating complications. Thankfully, these are quite rare, but things like major colonic or gluteal ischemia. There's also quality of life problems with coil and coverage. So there was a questionnaire study done by Farmand et al. That looked at quality of life symptoms after internal iliac artery embolization, coil and cover for aneurysmal treatment. This occurred in about 25% of almost 600 patients treated with EVAR. And they found that patients who had coil and coverage of their internal iliac artery reported buttock and thigh claudication at a rate of 50% at 1 month and 34% at 1 year. And in addition, 20% reported symptoms of sexual dysfunction. So this is not a benign treatment option, even though it can provide a durable seal. And there can be downstream complications as well as immediate quality of life complications noted by the patient. So what are some of our current endovascular treatment options to be able to seal a common iliac artery aneurysm while preserving internal iliac artery flow? There's currently only one commercially available device to do this. That's the Gore iliac branch endoprosthesis. This is an off-the-shelf treatment that was FDA approved in March 2016. Here are the two segments of the device and just some brief technical points. This requires an aorta to iliac bifurcation distance of 5 centimeters with an internal iliac artery landing zone of approximately 10 millimeters in length. It utilizes a precannulated up and over wire to be able to access the ipsilateral internal iliac artery limb. The main device is delivered through a 16 French sheath, and it utilizes a contra up and over 12 French Gore high flex dry seal sheath to be able to place the sealing internal iliac artery stent in place. What are some of the device limitations which these authors hopefully look at in this paper? Well, one is that the self-expanding covered stent is limited in its overall length. So it's a 7 centimeter stent. It requires a somewhat bulky delivery system of 12 French. And most importantly, it has a shaft length of 63 centimeters. So if you're going up and over previously treated flow dividers, previously treated aneurysms, or coming from an alternative access such as the arm or axillary artery, you have limitations in terms of the overall shaft length. By comparison, the Gore BBX balloon expandable stent graft was FDA approved in January 2017. This is a 7 or 8 French device, depending on the size of the stent chosen, and comes in a variety of lengths from 29 to 79 millimeters. One of the notable features of this device is that the 8L size can be post-dilated from a nominal diameter of 8 millimeters to an enlarged diameter of 16 millimeters, which gives a wide variety of size range. And again, the shaft length is 85 to 135 centimeters, which obviates some of the problems that you get with the self-expanding stents. So with that, I will turn it to Dr. Healy for her description of the paper. Thank you.
Good evening. I'm Laura Healy. I'm the first-year fellow at the University of Connecticut and Hartford Hospital Joint Program. And thanks very much for having me in today. I am here to present a paper out of the University of Texas and Mayo Clinic called Outcomes of Balloon Expandable versus Self-Expandable Stent Grafts for Endovascular Repair of Iliac Aneurysms using iliac branch endoprostheses. So aneurysmal iliac arteries should be treated with iliac branch devices at the time of EVAR to preserve internal iliac flow. As Dr. Gifford just mentioned, there are benefits to that. Gore iliac branch endoprosthesis is the only commercially available and approved iliac branch device. And the internal iliac artery is supposed to be sealed with a 7 centimeter self-expandable stent graft, but there are benefits to balloon expandable stent grafts as well for internal iliac sealing, in that they are lower profile and therefore more easily trackable. They have increased radial force and they have more precise deployment. They also have a wider range of lengths and diameters available for use and a longer delivery system for the up and over technique, as previously mentioned. They can also be expanded to 16 millimeters. This study was a single institution retrospective review from Mayo Clinic from 2014 to 2020. It compared internal iliac stenting with self-expanding versus balloon expanding. And the major adverse events were 30-day mortality, EBL of greater than a liter, myocardial infarction, respiratory failure, acute kidney injury, ischemic bowel, stroke, and paraplegia. These patients were followed up with CT scans at 1 month, 6 months, and annually. And they defined one of the outcomes is branch instability, which they defined as branch occlusion, a disconnection between the stent grafts, endoleaks, and need for reintervention. In terms of results, during this time frame, there were 121 patients treated. 31 of those patients were excluded because non-Gore branch devices were used. So that left a total of 90 patients who had 108 iliac branch device grafts used. 86 of those were male and 4 were female. Balloon expandable stent grafts were used more often in prior EVARs, patients who had prior EVARs, and also patients who had type 1B endoleaks. As you'll see there, those were both statistically significant results. In addition, patients who got balloon expandable stents also had larger maximum diameters and larger minimum diameters. Table 2 here shows additional results. So the technical success was quite high in both groups, 97% for the balloon expandable group and 100% for the self-expanding group. But balloon expandable had a few differences, and they were used more often in isolated iliac branches. They were also used more frequently in the up and over technique because of the shaft length, as previously mentioned. And they were more often used outside of the IFU. And this also was associated, they were used more frequently in more complex aneurysmal disease and internal iliac artery anatomy. And because of that, had longer operating times and longer fluoroscopic times. In terms of early outcomes, within 30 days, there were 2 deaths. Both of them were in the self-expanding stent group. 1 death was from sepsis and 1 was from an unknown cause. There were an additional 8 major adverse events. 4 patients had an EBL greater than 1 liter. 1 patient had an acute kidney injury, and 3 patients had access complications, which required reintervention. These major adverse events were not statistically different between the balloon expandable group and the self-expanding group. In terms of midterm outcomes, the self-expanding group had a longer follow-up of 28 months as opposed to 20 months. And there was a higher incidence of branch instability in the balloon expandable group, although this did not reach statistical significance, and we'll go over that in a little bit. They were similar in terms of their outcomes for buttock claudication, primary patency, freedom from endoleaks, and freedom from reinterventions. In terms of branch instability, you'll note that there were 4 patients in the balloon expandable group who had endoleaks and 1 in the self-expanding group who had endoleaks. And although the numbers are quite low here, the ends are quite small and they don't reach statistical significance, it is worthy of note. And the type 3C in particular have 2 endoleaks for the balloon expandable group. And as we mentioned, they're being used in more complex internal iliac anatomy and more distal branches. So in conclusion, there's a high technical success, a low morbidity and mortality for treatment of common iliac aneurysms, internal iliac aneurysms, and type 1B endoleaks after EVAR by both balloon and self-expanding stents. There is a 94% patency for self-expanding stents at 2 years and a 100% patency for balloon expandable stents at 2 years. There are some limitations of the study. It is a retrospective study. It is a small sample size in a single institution. And also there is a significant amount of anatomic variety and variability that I think I alluded to. The balloon expandable group definitely had more complex anatomy, which led to this higher degree of branch instability. They were more often used in smaller divisional branches, more often used in the up and over technique because of the shaft length, and more often used outside of the IFU. So this definitely contributes to some of the findings. So that's it in terms of presentation for the paper. Thank you very much for having me, and I look forward to hearing from the authors.
Thanks, Dr. Healy. Great presentation, really well done. I think first question I have is, did the authors see any difference in surgeon preference on what stents were used? Do some surgeons tend to preferably use balloon expandable versus self-expanding more? And did that kind of factor into decision making?
Yeah, sure. Well, thanks for the opportunity to be here tonight. Unfortunately, Dr. Rodriguez is not able to be here, but hopefully I'm going to be able to address all the questions. So if that matter, well, most part of the cases actually in this that we have so far are with gore, but we have a lot of cases also from Cook at this point. I would say that a lot of patients being treated by FBVAR, we do also IBEs at the same time, and for all of those we use VBX, right? Because Cook doesn't have an internal iliac stent. Well, with that being said, for these other patients here that are mentioned in this paper, I would say that usually if the anatomy is good and if it's adequate, we would go with actually the internal iliac device from Gore. But as you can see, a lot of these patients, they do have not a very good anatomy, so they have internal iliac aneurysms. A lot of them have actually a very tiny vessel, and others a big vessel. So in those patients, we would usually go with a VBX. But if the anatomy is good, we would use the instructions for use of the Gore device, and we would go with the Gore iliac internal device.
Can you comment? I think you know the answer to this. Can you comment on not doing risk-adjusted analysis here and the reasons for not doing that?
Sure. Yeah. Well, I think that's a very good actually comment. I would say that this paper was really meant to be somehow a descriptive paper, showing that balloon expandable stents are a good option for these patients. However, yeah, I mean, I do agree with you. These groups are definitely not comparable. The anatomy is much worse in the patients that had balloon expandable stents. But we have just a few patients on that. So I would say that if we would do a match control group, probably we would not have enough patients to do any analysis at this point, since we only have 90 patients included and less than 40 in the balloon expandable stent group.
Well, I think your denominator is high, but fortunately your numerator of complications is pretty low, which is probably the main reason for not doing that. So I think that's a good problem to have, I guess, in a lot of ways. And I think one of the questions I had was, generally it looks like, VBX is used more complicated cases, and more complicated cases tend to have worse outcomes. What would you recommend for someone who's doing a straightforward IBD case tomorrow? Should they try to use a VBX, or should they stick with the traditional one?
Yeah, well, if you're going with Gore IBE, which is
yes.
Actually what we're talking about here, and it's a straightforward case, I would go with the instructions for use of the device, and that would be the Gore internal iliac device.
All right, we have a question from the chat. Do the extension into internal iliac divisional vessels affect branch patency?
Well, that's a very good question, actually. So what we have so far, actually, we have a multi-center going on, so I can talk a little bit about that and expand a little bit on this. I'll tell you from what we have so far is we have a little bit over 170 patients enrolled in that study from multiple centers. And the patency rates there in 2 years, they were quite high, around 80% in the patients that actually have the anterior branch of the internal iliac artery as the landing zone, and above 90% on patients who had posterior iliac, the posterior branch of the internal iliac artery as the landing zone. So in that paper, actually, we showed that landing the stent graft, usually a VBX or whatever you use in the posterior branch of the internal iliac artery, we have a better patency over time. But yeah, I think that would probably answer the question better than with the data that I have for this study here.
Dr. Forbes had a question for internal iliac artery aneurysms. Do you have a preference of which branch to land into?
Yeah, well, I think what I just said kind of answered that question. We didn't know before that. Usually the posterior branch, from our experience, is a better vessel, a little bit bigger, and the length is also a little bit better to land a stent graft there. And well, we have recently found this number then so a better patency using posterior branch. So we would usually go with that.
Okay, Dr. Bachara had a question. Switching to a 11 millimeter VVX instead of 8 due to significant shortening at the gate. He wanted to know any technical tips about that.
Well, that's a great question, but I'm sure that at this point, Dr. Bachara knows better than me. But that's an issue. But I don't have experience or data to actually answer that question.
Gotcha. And really nice job. You know, it's a quote unquote small series, but it's very large. So, you know, you should be congratulated for a very nice job with the paper. We enjoyed reading it.
Thank you. We appreciate it.
Another question in the chat. Feeling that coil embolization of the internal iliac is actually more time consuming than an IV iliac branch device. Any thoughts on that?
Well, that's a good comment. I would say that overall, yes, at this point, seeing Dr. Odrich doing so many of this, he does it quite fast. Actually, today, he took an extra, I would say, 15 minutes to do an IBE. So it's actually quite fast. And yeah, when you actually are coiling the internal iliac artery, you need to deploy several coils, or well, one unplatzer plug that will do the job as well. But I do agree with that comment. I think that more and more, as we have more experience, we do it faster. And well, I think that's a huge benefit for the patient. So even if it was a little bit longer, I would still try to do it. And I mean, the time at this point is pretty much similar. So I do agree with that comment.
Dr. Syracuse, do you think we got all of the questions? It kind of looks like it.
I think we did.
Wonderful. Thank you very much. What a great discussion. I also liked seeing Dr. Forbes and everyone commenting on how their experiences has changed with this, because as new technologies come out and as we start to learn and use it, we all get new skills that we pick up. Well, we want to thank everybody for a great conversation, 2 articles that are exceptional, really kind of highlighting what's going on in our field. And I really appreciate everybody being here. We will not be having a June session because we will all get together at the VAM, but we will be having a July session, and that will be posted, and we'll be publicizing that in the next couple of weeks, over the next couple of months. So thank you all for being here. We look forward to more discussion as the year goes on.
Thank you, Misty. Great job. Happy Mother's Day to the past weekend, and happy Father's Day next month.
Thank you. Good night.
Thanks, everyone.
Ciao.
Thanks, everyone.
Thank you so much.
Mm-hmm.